I would like to introduce our speaker today is Annemarie Shepherd. She is a radiation oncologist at the Memorial Sloan Kettering thoracic cancers, specifically thymoma, lung cancer, and mesothelioma. She works at several of the different sites of the Sloan Kettering Memorial, including the New Jersey site and the New York Proton Center in Manhattan. She has a long CV, but I think we can go straight into her talk. Thank you.
Hi, my name is Annemarie Shepherd, and I'm a radiation oncologist at Memorial Sloan Kettering Cancer Center. And today we're going to be talking about radiation therapy for thymic epithelial tumors. So what I'll go through today is the basics of radiation therapy, when radiation is recommended for patients with thymic tumors. We'll talk about some side effects of radiation therapy, and then also just touch on some different types of radiation. So the basics of radiation therapy. Radiation is part of a multimodality approach to treating patients with thymic malignancies. And I say multimodality, that just means that we work with our surgeons and our medical oncologists, as well as our radiologists and pathologists, to determine when, if, and what kind of radiation is most appropriate for a patient. And so, as opposed to surgery where you go to the OR and you have a surgical procedure, or chemotherapy where you sit in a chair and you have chemo going through the IV, radiation is very different. With radiation, you basically lay on a treatment machine, and radiation is targeted towards the area that needs to be targeted for the thymic tumor that you have. The way that radiation works, so radiation therapy is the medical use of ionizing radiation as part of cancer treatment to control malignant cells. So the ionizing radiation that comes out of the treatment machine, the way it works is by damaging the DNA of the tumor cells. So once the DNA of the tumor cells are damaged, it's very difficult for them to regenerate or reproduce, whereas normal tissues have the ability to recover from radiation, but the tumor cells don't. So what we see here, it's a patient laying on the treatment table. This is a therapist who's setting her up. And this is a very common radiation machine called a linear accelerator. And the radiation comes out of the head of the machine here and is directed towards the patient, precisely towards the target that we want to hit with radiation. Radiation has improved dramatically in terms of its technology and advancements over the past few decades. And so now, with the equipment we have, we're able to very accurately target areas that we want to target and avoid normal structures or areas we want to avoid with radiation. And the way that we can do that is by really modulating and affecting the radiation beam as it comes out of the machine. So this is what it kind of looks like inside the head of a linear accelerator. Basically what happens is X-rays are generated, and then as they're coming out of the head of the machine, they're modulated with different leads and different devices to make it as pinpoint as possible. And so a typical course of radiation is a patient comes in for treatment. Most typically with thymoma, we treat patients over 5 to 6 weeks of radiation. So patients come in every day, Monday through Friday, for 25 to 30 treatments. They come in, lay down, get set up, get their treatment, then go home. Treatment itself is just a few minutes. And so the way that the process for radiation works, so it's very involved to plan and deliver radiation. So this is kind of a typical workflow for how patients are planned for radiation. I first talk to a patient in consultation. We determine if radiation is necessary in their case. Then if it's necessary, how are we going to do it? Are we going to do a 5 to 6 week course of radiation? Or sometimes we'll do a 5-day course of radiation. That's something called SBRT, which we'll go into in a little bit. or sometimes just 10, 15 treatments of radiation. It all depends on a very specific circumstances for each individual patient's case. But once we decide that we do want to proceed with radiation, in general, the first step of radiation is getting set up with a simulation or a planning session to plan out the radiation that is specifically designed for each individual patient's anatomy and each individual patient's case. So for simulation, what happens is the patient lays on their back on the table. We make a mold to make sure that their position is as reproducible as possible, because when they come in for treatment itself, we want them in the same exact position each time. So we make a mold and then we scan them. We use that scan to plan the radiation. And before they get off the table, we make marks on their body, and we often put tattoos based on the way we want them to be aligned on the treatment machine when they come in for the actual treatment. So we use these lasers to help mark them at the time of simulation. We get the CT scan, and then we use that CT scan to map out the areas we want to target and map out the areas we need to avoid. So in this case, this is a slice of a CT scan of the chest. The black is air or lungs, the white is bone, and the gray is either muscle or fat. What you can see here in this area that's outlined, this is a thymoma, a patient who didn't actually go through surgery. And so what they have here is a thymoma that we're targeting with radiation. And so we map out this area to treat. We also map out the areas we want to avoid. So like the lung, the esophagus, the vessels, the spinal cord region. And we use the radiation planning software we have. We work with our physicists and dosimetrists to generate an individualized plan for each patient, figure out what beam angles to use, how much intensity to use, to target their areas we need to target and avoid the areas we need to avoid. That process takes about 1 to 2 weeks. So once we have a plan, then we also need to make sure that the plan can be carried out on the machine. That's a process called quality assurance. Once we've done all of that, we bring in the patient for setup. So they come in for setup and they lay on the table with the machine. We use those lasers to set them up according to the tattoos. Then we actually take images like low energy x-rays to make sure that their internal anatomy is matching their external anatomy. And so once all of that is verified, then we start the beam, meaning we start the treatment, we deliver the radiation. And the radiation is often delivered at many different angles. So the machine will move, give some radiation, move, give some radiation. So as the patient, you're laying there, you don't feel the radiation as it's being delivered. You may hear the sound of the machine being turned on and off, but you don't actually feel the radiation while you're getting it. The radiation moves in all angles, including from under the table. So patients often ask, if we have to treat towards their back, how we're doing that. We actually do treat through the table. And so while patients are in treatment, they're seen weekly, and then after treatment, we follow them up with scans and visits. So what are the different types of radiation we recommend? Most typically for thymic tumors, patients, we most typically do radiation in the post-operative setting, or PORT is what we call it, post-operative radiation to the thymic bed. The thymic bed is the surgical bed, so the area that was removed with surgery is often targeted with radiation. So how do we determine if it's recommended? After surgery, we look at the pathology very carefully. And if we see any high-risk features like positive margins, or if the thymoma is invading into other structures, or if under the microscope, it just looks like they are very aggressive cells, like thymic carcinomas tend to be a little bit more aggressive, then oftentimes we'll recommend that the patient undergo post-operative radiation every day, Monday through Friday, for 5 to 6 weeks. And so this is a case here where the post-operative bed was planned for radiation. This is our most typical case. Other cases, so if a patient has an unresectable thymoma, so these are either patients where their thymoma is too big or involved, that it would be difficult for a surgeon to take it out. Or if a patient medically is not an ideal candidate for radiation because they have medical issues, then oftentimes we'll do what we call definitive radiation. And what you can see here is this thymic mass, which is over here, which is being treated with this radiation beam here. And this radiation actually is proton therapy, which I'll touch on towards the end. But it's delivering radiation to this thymic mass, which is right in front of the heart here. And another indication for radiation is something called palliative radiation. So palliative radiation is often delivered for areas that are causing problems, or they appear that they may cause problems in the future. So this is an image of a patient actually I have on treatment right now. I'm treating her with proton therapy. She has a thymoma that has recurred in the lining of the lung called the pleura. And these areas in the pleura have grown, and now they appear to be encroaching into her spinal canal. So here is the vertebrae body. This white thing here is the vertebra. And this hole in the center is actually where the spinal cord runs. And so the thymoma, the pleural recurrence of her thymoma is starting to now approach into her spinal canal. So we're trying to shrink that off the spinal canal so it doesn't cause any problems to her spinal cord. And so this is what we're doing in a palliative sense to prevent a problem from happening. This last type of treatment is something called hemithoracic pleural radiation. This is something that's currently under investigation at Memorial Sloan Kettering. It's not typically done, and it's a very sophisticated approach to treating pleural disease with radiation. And it can be pretty high risk because there is a lot of lung that's exposed with this type of radiation, but pleural recurrences for thymoma are sometimes difficult to manage. They tend to recur. This type of pleural radiation we do standardly actually for mesothelioma, which arises out of the pleura. But we're investigating this type of pleural radiation to see if there's any benefit in patients with thymoma who have pleural disease. So let's talk about the side effects of radiation. So what are some common side effects of radiation? Fatigue and skin changes tend to be fairly common, and they tend to be fairly mild. So patients who, for example, want to work throughout their radiation course, they can absolutely work during radiation. They may develop some fatigue, but it's not this debilitating fatigue that prevents them from doing what they want to do. They might just feel a little bit more wiped out towards the end of the radiation, just as the radiation dose accumulates over time. In terms of skin changes, radiation can cause some redness of the skin, like a mild sunburn. In general, again, this is very, very mild. And so most patients actually don't really even notice it, but sometimes they do notice that it might be a little bit more red or pinkish or a little bit more tan. It's very rare to have severe radiation skin reactions like blisters or anything. That's incredibly rare. Some less common side effects. So the esophagus is sensitive to radiation. If our target is very close to the esophagus, sometimes people can get esophageal discomfort or what we call esophagitis. The esophagitis, the dermatitis, and the fatigue, those are all short-term side effects of radiation, meaning they peak soon after the radiation's done and then they get better. The esophagitis symptom can cause people as they're swallowing to have a little bit of discomfort. So we sometimes need to manage it with medications, but again, it's short term, it gets better, it completely heals. Lung inflammation can happen from radiation. That's something called radiation pneumonitis. If it happens, it occurs months after radiation, somewhere between 1 and 9 months after radiation. Patients can develop a cough or shortness of breath. The risk of developing it is somewhere between 10 and 15%. If patients develop it and it's severe enough that it's affecting what they want to do, then oftentimes we'll treat them with a course of steroids like prednisone for about 6 to 8 weeks or so, and then they'll feel much better. That inflammation can evolve into some scar tissue. which can affect the lung function in the area that develops some scar tissue, but that typically has a very minimal effect on a patient's overall lung function. I do, whenever I see a thymic patient in consultation, do spend some time talking about the cardiac risk and the secondary malignancy risk. So these are rare side effects of radiation. The rates are low and they're late, meaning they happen often decades after radiation. But thymic patients tend to be young, they tend to be very healthy, and thymomas in general are slow-growing diseases. So the consequences of radiation decades after treatment is important to understand when you as a thymoma patient are considering radiation. So in terms of the cardiac risk, I think this graph tends to describe it well. This is a study we did based off a cancer registry. So one of the things with thymic malignancies is that they're rare. So we don't, like in breast and prostate cancer, we don't have these large randomized studies to really be able to use level 1 evidence and data to show what the true risks of treatment are. So we have to use more registry studies, which this is a study of more than 1,300 patients with thymoma. Some of them were treated with radiation, some of them were not treated with radiation. So I want to focus you on the two curves on the below here. The red dashed line are the patients with thymoma who did get radiation, who developed a cardiac issue after radiation. The patients, this black curve are patients who have thymoma who did not receive radiation, but developed a cardiac issue after treatment. So as we see, as the years go by, the patients who had radiation, initially their cardiac events are low, but then around year 10 or so, the incidence of cardiac events does seem to increase a little bit, only by a few percentage points. But as you can see, once you get 10, 15, 20 years out from radiation, there's possibly a small increase in cardiac risk in the patients who get radiation. Of note, this curve was not statistically significant, but I do think that the way that the curves cross can indicate a potentially low risk for cardiac effects from the radiation. And it's also important to keep in mind that, so this was published in 2010, and some of these patients were treated with radiation 20, 25 years ago. So the radiation techniques likely used for those patients were probably much older techniques that probably delivered a lot more radiation to their heart, resulting in this slight increase in cardiac risk. So talking about secondary malignancies. So a secondary malignancy is basically a second cancer that develops after a patient's been treated for their thymoma. And radiation cures and kills cancer, but in and of itself, it is a mild carcinogen. And so we wanted to see in the patients with thymoma if radiation resulted in them developing more cancers. And so we looked at these 1,300 plus patients, divided them into radiation versus no radiation, and looking at all cancers, there was really no difference in the development of cancer after their therapy. So the patients who received radiation, about 11.7% of them developed a second cancer. Those who did not receive radiation, 12.4% of them developed a second cancer. Breaking it down into the different types of cancers, particularly in the chest region, the only thing is the lymphoma had maybe a 1% difference, 1.2 versus 0.2 in terms of the development of a second cancer. So there, we occasionally, very rarely, will see second cancers from radiation, but again, it's rare and it tends to happen decades after radiation. So let's just touch on a few different types of radiation. During the Q&A session, I can go through this a little bit more, but I often get questions about SBRT and proton therapy, so I'm going to focus on that. SBRT can be used in patients who have a target that is well defined, and often we'll do it for like pleural recurrences. Okay, so we take that 5 to 6 week course of radiation that we do for like the post-operative patients, and we condense it down into just 3 to 5 treatments. We give a high dose per day in a short period of time to control an area like a pleural recurrence that might cause issues in the future. So that's something, that's one of the indications for SBRT. Often people hear about CyberKnife when they start looking up radiation. CyberKnife is a form of SBRT. It's like a brand name for SBRT. So SBRT is one of the types of radiation that we can use, very much depending on the situation. And then proton therapy is a newer form of radiation. We've been treating with it for at least a decade. But the thing about proton therapy is what comes out of the machine is not an X-ray, it's a proton beam, which is a heavier particle, and we have that ability to stop that particle, that beam, soon after the area we need to target. So when you compare a regular radiation or a photon IMRT plan to a proton plan, as in these two examples, what you'll see is soon after the target, the proton beam can stop. So it really avoids any radiation going to the area of the heart behind the target. And so in that sense, it can deliver less radiation to normal structures that we need to protect from the radiation. There are some downsides to proton therapy, so it's not indicated in all situations. Protons, the centers are not very common in the United States because they're very large machines. So that what you can see here is what we call a cyclotron, which is where the protons are generated and accelerated. And the machines are huge. So you see the patient here is very small and the machine itself is very huge. There's a lot of technology and machinery behind these proton centers. And so protons are also very sensitive to different motion and to different parts of the body, like bone versus air versus fat versus muscle. So all of that needs to be considered when thinking about proton therapy for patients. So in summary, radiation commonly used to treat thymic malignancies as part of a multimodality treatment. There are different reasons to use radiation. There's different types of radiation, and different types have benefits in different scenarios. So it's best to talk to your radiation oncologist to determine the best indication and type of radiation for your situation. Thank you.
Thank you, Annemarie. I see we have a question up on the chat. Can I ask if anybody has questions, please type them into the chat window, and then I will relay them to Annemarie. Annemarie, the first question that we have is from Byron Goldstein, who asks, what about latent side effects like esophageal dysmotility?
Yeah, so absolutely. So in terms of the esophagus effects of radiation, the esophagus tends to be pretty sensitive to radiation. Most typically, we'll see esophageal symptoms in the short term after radiation, and that also depends on how close our target is to the esophagus. So thymoma in general tends to be in the front of the chest, and the esophagus tends to run in the back of the chest, like right in front of the spine bone. So typically for your average postoperative radiation case, the esophagus actually isn't getting a very high dose of radiation. But in a case where the target happens to be close to the esophagus, during radiation, you will get some esophagitis causing some discomfort when you swallow. That peaks after the radiation is done, and then it gets better. But in terms of late side effects to the esophagus, I would say that is very rare, especially for thymoma. Sometimes we'll see it like in our lung cancer patients where there's lymph nodes all around the esophagus and they're getting chemotherapy and higher doses of radiation. And so sometimes what we can see long term is that when the esophagus receives a high dose of radiation to a long length of the esophagus and circumferentially around the whole esophagus, that it could get a little stiffer and cause something like a stricture, which sometimes needs to be dilated. For thymoma patients, though, that is, even for lung cancer patients, it's pretty rare, but for thymoma patients, it's even rarer.
Thank you, Annemarie. Then Alan Watkins asks, what is the durability of radiation in terms of stopping disease progression?
Yeah, absolutely. So in terms of the effectiveness of radiation, so what we say in general And when we recommend radiation, particularly in the postoperative setting, is when we want to reduce that risk of the thymoma coming back. Thymoma does tend to be pretty sensitive to radiation. So when we estimate that a patient's risk of recurrence of their thymoma, if it approaches like 15% or so based on the pathology that we see at the time of surgery, then that's often kind of the tipping point for when we do recommend radiation. And then what we find is that radiation reduces the risk of it coming back by about a half. So we say, if your risk of it, we estimate your risk of it recurring without radiation is about 20%, radiation will decrease that to like 10% or so. And in terms of its durability, so when I say it'll control it, that means for the long term, meaning it shouldn't come back.
Thank you. Marina from Germany has two questions for her father, who was diagnosed in 2014. She says, what type of radiation would you suggest for multiple thymic metastases to the pleura on the right side? Is the first question. And the second, is stereotactic radiation also possible to the pleura if several surgeries have already taken place there?
Yeah, so I mean, that brings up a situation that we encounter frequently, and it's actually such a challenging situation sometimes. So pleural recurrences of thymoma are common, and when they happen, each case tends to be very different. And so we're saying if there's multiple thymic metastases to the pleura on the right side, what we typically try to do, if possible, we work with our surgeons to see if they could be surgically removed, because that would be preferable oftentimes if it can be done safely over radiation. If kind of the patients used up all their options for surgery and surgery is no longer considered the best approach, then we'll consider doing radiation. How we do radiation really depends on exactly where things are located and the extent of their location. So if there are a number of pleural metastases, we'll kind of take a look at them, see how quickly they're growing. If some appear to be growing a little bit faster than others, then we'll consider treating them just to kind of get them quickly controlled. Or if there are pleural metastases that look like they may cause problems in the future, like they're about to invade into the rib and cause pain, or into like the spinal canal, like I was showing before, then we'll target those areas so they don't cause problems. The way we target them all depends on how big they are, where they're located, and what the target's like. So if they're very distinct targets, then oftentimes we will use SBRT. That's like the 3 to 5 treatment course of radiation, high dose. If they're more extensive and it's bigger, then we tend to spread the dose out a little bit more. We give a slightly lower dose over a slightly longer period of time and may do like 10, 15, 20 treatments of radiation. It's hard to say upfront like what you should definitely get if you have pleural metastases, because pleural metastases are very, very variable. But in general, that's kind of how we think about them.
Thank you, Annemarie. That's actually a very comprehensive answer you've given there. The next question we have is from Carrie McDade, which is perhaps a radiology question rather than radiation question. She asks, if allergic to contrast, do you recommend CT scan without contrast or MRI for follow-up? You could potentially punt that one. I see we have Edith Marom online with us, who is a specialist radiologist who has a very specific interest in thymic imaging.
Hi, everybody. So again, the problem that we have with following patients with thymoma is that sometimes they can recur in where the surgery was done, specifically if no radiation was given to the radiation bed. And in those areas, there are many blood vessels, and the recurrence can enter the blood vessels. So we always have a question whether they're invading into an object. The problem with the tumor itself is that the color of the tumor is just the same as blood on CT. So if it abuts a blood vessel, we cannot see if it invades or doesn't invade. Another thing is the tumor deposits, when they go further to other areas, like to the liver from the pleura, go through the diaphragm to the liver, or if they go into other organs in the abdomen, those organs again are very similar to the tumor itself. So when they involve them, we cannot see it without the contrast. What the contrast does, because just like radiation, where the tumor doesn't behave the same as the normal organs of the body, this is the same situation when we give contrast. The normal organs of the body get contrast in a certain way and the tumor in a different way. So when we inject, even when there's tumor in the liver or in a vessel, it's different in density. So we're able to see it. That's the reason that we always insist on giving contrast, so we can see better, so we don't miss the recurrences, or so we can follow them accurately on treatment and see if they're getting smaller or bigger and be more exact. So to answer your question, we always like to give contrast, but so if you cannot get it with CT, then yes, it would be better probably to do it with an MRI. But the MRI has a disadvantage of being a very long examination and not very pleasant, and sometimes the insurance won't accept it. So if it really, again, comes back to where is your tumor, what is the situation, what am I following if there's already a recurrence, because sometimes we may be able every once in a while to do one without contrast, but the ideal is with.
Thank you, Edith. I think that's a very comprehensive answer. The next question comes from Jeff, who asks, would proton therapy be an effective treatment option for a thymic carcinoma that has extended into the pericardium?
Yeah, so in terms of the effectiveness of proton therapy, so proton therapy is still radiation therapy and still kills cancer cells in the same approach that regular radiation does. So the effectiveness of proton therapy is just as effective as radiation, like regular radiation therapy. So the difference is that where and how the radiation goes, you could potentially spare some normal structures a little bit better with proton therapy, again, depending on where it's located and other issues. So that is where the benefit for proton therapy comes in, not so much with the difference in effectiveness. It's just as effective, but it could potentially spare some toxicity. For a thymic carcinoma extending into the pericardium, generally those types of thymic tumors, we do recommend radiation. And so especially if it's invading into the pericardium, that area surrounding the heart, just kind of me trying to visualize what it looks like, I would anticipate that proton therapy would be able to spare some heart dose better than regular radiation, but it all depends on finally what the target looks like to really make that assessment. But I would think so.
Thank you, Annemarie. Trish asks, is radiation still recommended if a patient has received CAP chemotherapy due to increased risk of cardiac events?
Yeah, so that's a great question, because CAP itself comes with some cardiac risk, and similar to breast cancer, where adriamycin is often used for chemotherapy. So, we consider that when we're recommending, planning, and designing radiation, just the fact that that patient who's received prior chemotherapy that could have in and of itself some cardiac risk. So we think of them as a slightly higher risk, but at the same time, we have to weigh the risks with the benefits, right? So it then also depends on how aggressive the thymoma is in terms of what the recurrence rate would be. And so, if the benefit of controlling that thymoma outweighs the potential risk of cardiac related issues, then we will recommend radiation. And as I showed with those curves, so those curves are from patients treated with older techniques from radiation. Many of those patients, though we don't know the exact numbers because the registry that we looked at doesn't necessarily tell us exactly what type of chemo and stuff. But I would imagine, because chemo is often used, especially preoperatively with thymic tumors, that many of those patients also did have similar chemo. We still saw that, after 10 years, yes, there's probably a slightly increased risk for cardiac related issues, but it's probably small. So we keep that in mind when someone's had prior CAP. But we always have to weigh the risks and benefits, and so it really depends on how strongly radiation would be indicated to reduce a recurrence.
Thank you. Next question then comes from Lisa, who asks about scar tissue after proton treatment in the long term. Can it cause problems around the heart and the lung?
Yeah, so proton therapy, similar to regular radiation, in the long term, it can cause some fibrosis to occur, and fibrosis is basically scar tissue. The thought is that with proton therapy, since it's exposing less lung and heart to radiation, that level of scar tissue that develops can likely be less. But again, that depends on how extensive the target is and how we're able to get the radiation to the area that we want to target. In general, like I was saying, one of the risks of radiation is that it can cause inflammation in the lung, and over time that lung inflammation can develop into scar tissue. So that's possible, but we do find for the vast majority of patients, especially the thymic patients who have very good lung function in general, going into treatment, that the effect of that scar tissue usually doesn't have much of an actual impact in the patient's overall lung function. But again, that's very patient specific, depending on what their underlying lung function's like.
And then Steve Patel asks statistics on second malignancies in a young patient due to radiation. Is it type dependent? Is there a difference between protons and photons?
Yeah, so what I showed with those secondary malignancies is that, secondary malignancies do tend to be rare, but they are of much greater significance, especially in young patients. And especially, when we think about pediatric patients, that is something that we consider a lot. Is it different depending on protons? We don't have data to show that yet, but theoretically, we think that because we're exposing less radiation to the normal tissues, that may impact the development of secondary malignancies in the very long term. That is going to be very difficult for us to study because the rate of secondary malignancies as it is very small. And then the difference in how much of the normal tissues is actually getting exposed to radiation is variable based on the different types of plans. So I don't know if we'll ever have that data, but theoretically it should be slightly less. It's hard to say if that degree is, clinically meaningful or not, though.
And then Steve also asks, can a thymoma B1 invade lungs through pleural metastasis, and can radiation prevent it?
Let's see, one second. Can thymoma B1 invade lungs?
Lungs through pleural metastases, and can radiation prevent it?
Yeah,
so I think the question is whether if you have pleural metastases, it can invade directly into the lung, and would radiation prevent that from happening?
Yeah, so radiation can treat pleural metastases. Thymoma can invade, and thymoma, the WHO B1 can invade into the lung. It can develop into pleural metastases. I think, so if someone has a localized thymoma that gets resected, they don't have pleural metastases at the time of resection, and we do radiation just to the thymic bed, can that prevent pleural metastases? I think it's possible, but when we're treating the thymic bed, our intent is to decrease the recurrence that can develop within the thymic bed.
Okay, and then there's another question here that says, I have stage 4B thymic carcinoma. I was diagnosed 3 years ago, but have not had chemo or radiation to date. I have been referred to a radiation oncologist twice, once to palliatively address pain and once to help with swelling and cough, caused by suspected superior vena cava syndrome. In both cases, the radiation oncologist felt the percentage of radiation helping was less than 50%. Could this be specific to my case or in general, or is radiation really not that effective in these scenarios? Tough question to answer that.
Yeah, so I would say it's not radiation, like thymic cells respond to radiation, but I do have patients that I see, um, especially patients with stage 4B thymic malignancies that I don't necessarily treat right away because thymic malignancies in general do tend to be somewhat slow growing. And so we often have a discussion, risk versus benefit. Should we do radiation now or should we wait for a little bit? What are the pros and cons of that? So I do have a few patients that I'm just kind of following to determine, when should we pull the trigger for radiation. I do feel though that, if the thymoma is causing pain, if it's about to cause SVC syndrome, which can be pretty significant, then oftentimes I would recommend doing radiation. I mean, it all depends on the situation. And it's also a very multimodality approach. We have to talk to the medical oncologist, see if we should do chemotherapy, talk to the surgeon, see if there's any recommendations for that. So it very much depends on what's going on at that time, what it looks like, what the radiation field looks like, how big that radiation field is going to be, and how things have been progressing over time before we make the decision whether or not to do radiation, watch it for a little bit. But if it's causing problems, we will often do palliative radiation.
Thank you, Annemarie. That seems to be all the questions we have. Oh, a couple more just came in. From Steve Patel again, MRI better over CT considering probability of cancer development? Perhaps that's a question for Edith again.
Okay, so, the amount of radiation that a person receives from imaging is extremely low. I know that sometimes the fear from getting a CT is such that a person doesn't want to get the CT. It's really out of proportion because it's it's like 1,000, 10,000 less than the radiation we deliver as treatment. These are two totally different things. The data that we have from damage from radiation does not come from the imaging of patients with just a tiny bit of radiation again and again and again. The main data that we have is from Hiroshima and Nagasaki, where a large portion of radiation at one time was given, very similar to the radiation we give for treatment. For treatment, we have to have it because we need to kill the tumor cells, and it's great, it's wonderful. But with the imaging, there is no proof that with a CT several times a year, again and again and again, we're actually causing any cancer. So because it's dwarfed by the treatment that one gets, it's so little that shouldn't really be even in consideration. And one also has to remember that we're not doing the imaging to an asymptomatic patient without cancer, and finding just nonsense we don't need to find. Here we're talking about finding early disease which we can control to save lives. So it is important to do it. And you shouldn't be afraid of it because of that, because the whole thing is that people who get it for following cancer are at increased risk, and we need to catch it early. So it's definitely worthwhile.
Thank you, Edith. Then we've got a question from Ruth Priestley that asks, is there a lifetime maximum dose of radiotherapy that can be tolerated? And is that the same for proton beam therapy?
Yeah, so just to say for proton beam therapy, it's the same, the kind of the dose of the radiation is pretty much the same as regular radiation. But so when we talk about the lifetime maximum dose of radiation, so oftentimes people will be counseled that, you can only get radiation once. So that is usually meant for a specific site of your body that, in general, we only want to treat one side of the body once. That said, there are definitely situations where we have to do repeat radiation. And so when we do repeat radiation or reirradiation, we always have to, very carefully consider that, because with an additional full course of radiation, the risks increase. All the different normal structures that we have, like the esophagus and the lung and the spinal cord, we have in our radiation oncology world certain dose maximums that those structures can get. But what we've been finding over time, and also very, more recently, is that we can kind of push those limits of those structures a little bit and still control a tumor and minimize the risk of damage to those structures. So whenever we're planning radiation, we do plan for the patient to likely only need to receive one course of radiation, but there are situations where we need to do repeat radiation. So I don't like to say that there is a lifetime maximum dose. It all depends. It's a very, it depends on the specific situation. And we do rear radiation if we have to, but those are very, very specific and select situations.
Thank you. And then Steve asked another question, which I think Edith has already answered. The period span of thymoma CT were done 20 times, so probability increase is considerable. So MRI, even expensive, be beneficiary? Well, I think Edith has answered that question already.
Yeah, I think
in reality, the dose is small.
That came in after Edith was talking. And I do have to say, I completely agree with what you said, Edith. And I get a lot of questions about that too. Are we over surveillancing people? And from my perspective as a radiation oncologist, the amount of radiation that you get from a CT scan, as you said, is really like so negligible compared to the amount of radiation that we're doing therapeutically. So even a CT done 20 times is not even getting close to approaching the amount of radiation that you're getting for radiation therapeutically. So yes, MRIs have less radiation, but the risk with a CT scan is so negligible, even over 20 times, that it's most important that we surveil for cancer.
Great, thanks. And then I think that was actually the last question. Any other questions? I don't think I've missed any questions there. Annemarie, I think you've done an excellent job of answering some very difficult questions. Some of the questions that you've asked are touching onto controversial topics where we don't have a simple, straightforward answer that there's a right or a wrong, and it's very, very often dependent on the individual circumstances as to what the exact decision is.
Absolutely, that's very true.
See lots of thank yous coming in. Margaret.
Okay, so thank you all. Thank you, Annemarie, for this perfect talk about radiation oncology. Thank you, Conrad, for moderating this webinar. Edith, thank you for your comments. And thanks. I'd like to thank all of our participants that you had so interesting and important questions to our doctors. And just a short information, we are going to organize next webinar about chemotherapy at the beginning of May. It will be the 4th of May, and official announcements will be available on our webpage soon, so please visit our webpage, because we have next webinar for you in our plans. So thank you very much, all of you, and I hope to see you next time. Thank you.